folks. Welcome to the last unit, Unit 3. We're going to be talking, it's all about identification. How do we go about IDing a body? Now we've gone through the process of understanding how we find the bodies and how we understand the skeletal system and what we're looking at. Then we went into trauma and how to understand some of the traumas that we're going to look at. Now we're going to try to put a name on the decedent. Now we're looking at the individual as an individual and trying to figure out who they may have been. The first step to doing that is determining their age, their sex, and their stature. Notice that we said sex, not gender. Gender is a cultural construct. It is not biologically determined. Gender is whatever the individual decides to choose. Sex, on the other hand, is fundamentally you are male or female. There is very little ambiguity. There is no admixture. There are some cases, but very few, of somebody who is intersexed, being like the XY chromosomal abnormalities or incomplete X, or hormone therapy. These things will have an effect, but they won't change it that much. And to be honest, it'll just add to the ambiguity, but not really foil everything. So the skull is the second most indicative anatomical feature of sex in the human body. The pelvis is by far the best. All of these ideas are based on something called sexual dimorphism. Di means two, morph means shape. So sexual two-shapeism. The understanding that if there are two sexes of a given species, they will differ in shape and or size. The most dramatic, and the reason that I have an image of gorillas here, are gorillas. Gorilla males are nearly twice the size of the average gorilla female. Sexual dimorphism follows basic principles. That is, in our species, males are usually slightly larger. Not the dramatic thing that we see in gorillas. We only see males being about, on average, 10% larger than our females. However, this isn't a guarantee, is it? We see larger women all the time. We see women who are more robust than men sometimes, depending on what they do. But those things can actually help us determine what we're looking at. They are still skeletally going to look female, especially in their pelvis, if they are female, even if they're very robust or very large. Childbirth is what makes the female pelvis very unique. It is geared toward that. It's got a birth canal that males do not have, so it tends to be wider and broader. Males, on the other hand, tend to have much more robusticity, that is, higher muscle content. Males' muscles are usually more densely packed than females, and they usually develop much quicker. But there's more than that. It is driven by hormones. So at puberty, males develop larger muscle origin and insertion points on the bone than do females. This has nothing to do really with building that muscle up. It has everything to do with hormones saying they will. Therefore, this is an adaptation that happens. So males tend to be what we call more robust than females, but not always, and we'll see how there's some abnormalities there too. Sexual dimorphism, as I mentioned, is hormonally controlled. It's evident in adults, not in children. We cannot perceive the difference in prepubescent children between male and female. It just does not show up. It can vary within a population and between populations. So you can have very large women or very small men in a given population, or you can have the expectation is going to be more divergent in certain populations than in others. There are certain populations where everybody tends to be smaller and certain populations where everybody tends to be larger. So we'll see those differences happen, but that has a lot to do with ancestry. So you're going to see throughout this entire unit, we cannot do one without knowing some of the other. So we're going to talk about ancestry, and we're going to talk about age, and we're going to talk about other aspects, and all of these things have to be taken into account before you can answer any of them. So, as we mentioned before, the pelvis is the most clear anatomical portion of the body that tells us male from female. Females tend to have larger, broader, wider pelvises than do males. For example, as you see here in this image, the subpubic angle, what we're talking about here is this angle here. In males, it would be much more acute. It'll go more like that. In females, it's much broader, a wider angle. Same thing over here in the sciatic notch. We're going to see a much wider sciatic notch than what we see in males. This is the front here. We're facing this way is the front. So this is toward the back side, kind of in the hip area. In fact, this is the acetabulum where the femur meets up with the pelvis in order to make the hip. So we're going to see a wider here in the front. This is the front area here. We're going to see the wider sciatic notch. The sciatic notches are right back here and behind. And we're going to see, obviously, a wider birth canal. This includes, this here is called the sacrum. The sacrum will tend to not curve in as much on females as it does on males. So on males, everything is narrower. This area here, the birth canal, literally, is narrower. This angle is narrower. The sciatic notch is narrower on males than it is on females. Here's a very male pelvis. Now you'll see the blatant difference here. Look at how narrow that subpubic angle is. Look at how narrow the greater sciatic notch is. And if you look in this front image here, look at how tiny this canal is. There's no baby going to fit through that. Does that make sense? Males are designed for bipedal locomotion. Therefore, everything's gotten very narrow. Females are designed for both bipedal locomotion and childbirth. So you have this compromise going on. The pelvic girdle is usually indicated by single bones. As you noticed probably in that last picture, we have the os coxa on the left, the os coxa on the right, and the sacrum down the middle. It's three fundamental bones. We're often only given one or the other. So the key here is to look at that sciatic notch, which is here. If it is generally 3 centimeters or narrower, it is usually male. Okay? Over here, we're looking at the subpubic angle, and here we're going to take the angle, instead of having them both coming together, where you get this greater angle like this, now we only have one to go by. So we've got to measure straight down. This is called the pubic symphysis. It's where the two halves of the pelvis come together in the front. And then you go straight down here. Now you're seeing I am now creating an angle here, a triangle. Then I can measure the width of this angle. Okay? The skulls are the second best way of determining male from female. Fundamentally, I always say looking at a skull is very similar to looking at a black and white photograph of a human with all their hair shaved. Can you still tell the difference between male and female? Yes, you can. So what we're looking at here is overall size and that weird word robusticity, that robustness of the skull. The larger and more robust skulls tend to be the more male. Supraorbital torus, also known as the SOT, that's really your brow ridge. The supraorbital margin, which is the margin in the upper eye. Orbit is the eye socket. So supraorbital torus is the brow ridge. Supraorbital margin is the margin right between the roof of the eye and curving around in the eye socket. It's kind of hard to explain, but I'll show you pictures in a minute. The chin, males tend to have a more squared off chin. Females tend to have a rounded or pointy chin. Teeth are usually larger in males, particularly the canine teeth. We'll see that in a minute. The canines, those are your vampire teeth. Those are the teeth over here in the corners of your mouth. As you smile, you can see them quite clearly. Muscle ridges are usually larger in males, even in those areas where the muscle doesn't build up. For example, if you have big muscle ridges on your cheeks, is that because you've been smiling a lot? Not really. It is, again, going back to that hormonal thing. When the androgynous hormones kick in during puberty, that's when we see these muscle attachment points start to get larger, these ridges. The external occipital protuberance, that's on the back side of the skull, is often much more prominent in males. Don't worry, I'm going to show you pictures of all these things. The mandible, that's your jawbone, is usually much more large and blunt. It's smaller and sharper in females, as we talked about with the chin. Also, there's a little thing going on with the angle of the mandible, which we'll talk about in a few minutes. The mastoid process, those are the processes that you can feel, those little lumps that are right behind your earlobe. If you feel your earlobe and go right behind it, you'll feel a lump coming out of the base of your skull that connects up to a muscle. That strap muscle actually helps you turn your head. Generally speaking, those are larger in males because, again, it's a muscle attachment point. Cranial bossing are usually much more prominent in females. Again, I'll show you what those are in a minute. Forehead. Males tend to have a more sloping frontal. That is, their forehead tends to slope back from the brow ridge more so than females. Females tend to have a much more upright, kind of a wider, taller forehead. Here we are looking at a male and female jaw. These don't look that much different in this image, and I apologize for it, but there's an attempt. Basically speaking, the male jaws tend to be wider. They tend to have a more pronounced eversion going on right here. This angle here is called the gonial angle, and it tends to be everted. It looks like somebody pinched and pulled outward on either side. That's because that is, again, a muscle attachment point for the masseter muscle, which helps you chew. Females tend to have a smaller, less pronounced eversion here. You can see this bumps out just a little bit, but when we see real pictures, it'll be much more clear. The teeth tend to be smaller. This angle, and I'll show you it from the side, tends to be greater in females and tends to be more almost 90 degrees in males. This angle here coming up. And then female chins tend to be a little pointy and a little narrower from edge to edge. Really what we're doing is coming straight down from the canine teeth. And then look at the width here. Whereas males coming straight down from the canine teeth is much wider and squared off usually. Sexual characteristics in the rest of the skull. Here's our supraorbital torus. Again, now what we're looking at is that brow ridge. This is that bump here. The supraorbital margin is right along here, and it actually feeds into this torus. The toroid shape here is this big rounded, almost like if you're working with clay and you make a little worm of clay. That's kind of, if you lay it across a male's brow, that's sort of what you're looking at here. So it tends to be, this margin tends to be smoother and more rounded in males. In females, it tends to be much sharper. And I'll show you some images of that. The muscle ridges, like up here, down here, and the external occipital protuberance here, the mastoid process, all of these are muscle attachment points, and they tend to be much more robust in males. Chin tends to be squared off. That gonian angle, you can see it's now bulging a little bit. And you can see this angle. This is the angle I was talking about in the last slide. See this? Nearly 90 degrees in a male. In a female, it's going to be opened up, a wider angle in females. Same images side by side from a male to female. Here you can see clearly the male skull, which is the one on the left, is a larger, more robust skull. You can see all those muscle attachments are a little bit larger, a little bit more pronounced. Also, you see how the male skull tends to sort of slope backwards, the forehead, from the brow ridge to the kind of middle of the skull, whereas the females tends to be a much more vertical forehead. Nearly no brow ridge. Usually there's a little bit going on here, but not much. Not compared to this bump out that we see in the males. And we see that there's a lot of this smoothness going on in females. The mastoid processes tend to be smaller, and incorrectly drawn here, this female jaw would usually tend to be a little bit more wider angle than what we see in the male's very tight angle. We'll see all this when we see actual pictures in just a minute. Here we have a comparison between a typical male, and typical female skull. Now granted, they cheated it a little bit by tipping the female skull down a little bit out of what we would call Frankfurt horizontal, or the Frankfurt plane, but nonetheless, that's done for a reason, and I'll explain that in just a second. First of all, we're going to look at the male skull. First of all, notice down here, these are those gonial eversions that I'm talking about. You see how these are bumped out, almost like you grab this corner of the jaw from the back side and pulled it out to the side. This is a muscle attachment point for the masseter muscle that goes from here up to here and helps with chewing. Up here, we've got a much larger, more rugose brow ridge. We've got that sloping skull. We've got these really blatant temporal lines, which is another muscle attachment point. We would have a rounded supraorbital margin in here. We again have muscle attachment points that are relatively pronounced, squared off chin, and very large canine teeth. Here on the female side, we have this rounded chin, much smaller. It's not as rugose, all of these little muscle attachment points. We see very little gonial eversion back here. Then we have a much sharper orbital margin, nearly no brow ridge. Furthermore, you see these little bumps here and here. Those are those cranial bossing that I was talking about before. It looks almost like if you had taken a clay pot and you used your thumb and pushed out from inside. They're just little bumps, okay? This is actually a sexually selective aspect of the female skull. We'll talk about that much later on, maybe. Furthermore, we'll see the same bossing on the backside of the skull as well. It tends to show up in female skulls, not in male skulls, and it tends to be kind of prominent in some female foreheads. So that's where you look for it, but that's the best image I have of a really good cranial bossing, okay? Females also tend to look very gracile. This means the opposite of robust. It's from the same term as graceful, same root word. Robusticity means big, rugose, whereas gracile means slight and small. So the idea here is, if you look at these two skulls side by side, you can pretty much clearly figure out, okay, the one on the left is most likely male, the one on the right is probably female. Age estimation. Now we're getting into very difficult territory. In juveniles, almost the opposite of sex determination, in juveniles this is very easy. It becomes much harder the older people get. We're going to see that the age estimations can go from within months with a newborn or a young child. We can get it down to a matter of months. As they get older, we can get it into a matter of years in juveniles and young adults. Then we start slipping into 5-year categories. And then in old age, like we're talking from 50 to about 80 to 90, 100 years old plus, we start going into decades, because it's a lot less clear as to what we're working with. I'll walk you through why those things are and how we determine age when we're looking at a skeleton. Estimating age of a skull. Forensic science needs to work with law enforcement, so we have to give them a reasonable age grouping. After dental eruption completes, age is very difficult to estimate using only the skull, but there's a lot of other things that we can use to determine age. The skull is very, very useful, especially early on. The skull can tell us a lot about the age of an individual. The cranium of an infant is divided very clearly. It tends to have more sutures. The sutures have these holes in them, which are called fontanelles. That's where the sutures come together. This is a growth area. There's no bone here. So if the hole there is a fontanelle, you know you're dealing with an infant skull. Okay? Moving on, the neurocranium is much larger in relation to the face and mandible between ages 0 to 5. In other words, their brain case is huge and they've got tiny little faces. That's because that brain is growing very fast. That's also the reason all of these sutures are considered what we call open. Now, after they get older, we start seeing those sutures fusing together and going away. This is where we start getting into the decades of difference. It's tough to say. Studying a skull that's 6 to 21 years of age, we have a lot that we can work on, but the key is dental eruption. It's the most accurate. And the skull is usually about full grown, but the face goes through a lot of changes. So we'll talk about these things piece by piece. First of all, let's look at the sutures. At around age 20, the sutures are still what we would consider open. Now, this is where the different plates of the skull are growing together. And you can think of a suture. That's these squiggly lines on the top of the skull that we're looking at. You can think of these sutures as fingers that are kind of interlaced, and they hold together that way. We met these things in trauma when we were looking at explosive trauma that would pop these things apart. As the individual gets much older, like into their 70s, 80s, 90s, we start to see these sutures completely obliterate. Here you can see, over the age 70 person, this suture, this is called the sagittal suture, and the lambdoidal suture are almost completely obliterated. They're going away. These bones have now fused together. These sutures will obliterate at different rates, and we'll talk a little bit more about that later on. Newborns with teeth are the easiest to determine. First of all, they have no teeth. Their two sets of teeth buds are still within the jaw in what we call the crypts. So you can actually help to determine whether you're looking at an infant jaw or a non-infant jaw by shaking it, because those little teeth will rattle on the inside. Ages 1 to 3, primary teeth, these are the deciduous, also known as milk or baby teeth. These are all coming out now. By the age of 3, they've got them all in. By the age of 4, 5, and 6, they start to lose those teeth and replace them with the permanent teeth. All of the adult teeth, the permanent teeth, will be in by age 10. Now, these dates and times have changed a little bit over recent years. It's mostly because of prenatal and natal health care. That is, the babies are getting a lot of nutrition and they're growing very well, very quickly. So we're seeing these tooth eruptions moving forward just a little bit. I'll give you a really good example. As we get into young adult, the jaw starts to get larger and thicker. The jaw shows a complete set of all the permanent teeth, that is 32 teeth. The third molar is apparent, and it used to be called the wisdom tooth, also known as the 21-year molar. Not anymore. Nowadays, most of you that are watching this probably got your third molar or your wisdom teeth probably came out closer to age 17, 16. You can see this is a slightly older slide. It's only a few years old, but by now, it's already changed. Old age, now we start to see tooth erosion and tooth loss. Although we know people can lose all their teeth at a very young age. It happens. It's more rare, but it happens. We also tend to see more and more tooth reconstruction, especially these days. So you'll see a lot of crowns, a lot of fillings, those kinds of things start to happen more and more in old age. Tooth eruption schedule. Now, do not write this down because it has changed. Notice here we've got the central incisor on the lower mandible. This is, I'm looking over here on the left-hand chart. Central incisor down here. These are the baby teeth on the mandible, all right? The lower jaw. Central incisor used to show up around 6 to 10 months. Not anymore, you guys. Now it's showing up at 3 to 6 months. Most babies will have those two lower teeth, and quickly followed by the two central upper incisor teeth. Those are your Bugs Bunny teeth. These are the ones that come in first. These are usually showing up 8 to 12 months. Not anymore, you guys. Now we're seeing them in 6 to 8 months fairly regularly. So everything is sped up. And again, that's because of this neonatal healthcare and nutrition, really. Then we go into the adult teeth. The adult teeth eruption is, again, a little bit more common, a little bit more scheduled normally. We see the lower and upper third molar usually popping out right about 17 to 21 years of age. Oftentimes, though, it's happening a little bit earlier now. So it's going to start to speed up again as healthcare and everything else gets better. Postcranial age estimation. This is the rest of the body. What we look at here are epiphyseal, meaning at the end of the epiphyseum, meaning the end of the long bones. The sutures are starting to close. So what we're looking at is these growth plates. We met these before, but you see this line going along here? These two bones are still separated. They're starting to fuse. This is a young adult, but get it any earlier and you can actually separate it quite easily. Or there may actually be a huge distance. Like a child, maybe age 6 or 3 to 6 years old, would have this fusion plate stopping here and this bit here. So all of this would be cartilage in life in a younger person. This is problematic sometimes when we're looking at baby, especially neonate or infant bones. They can be easily mistaken for other animal bones, which we talked about in the very first unit. Round about the age of 24 to 26, somewhere in there, the clavicle, that's your collarbone, is the last bone to fuse. So some of you may not actually have full fusion yet. Now, osteon growth is different. We can look at osteons. This is taking a super thin slice of a bone, putting it under a microscope, and looking at the osteons. These are the bone building cells. This is what builds up a bone. And what we're actually looking for are complete osteons. Do you see these little circles? They look like a bunch of straws end on. But we see spaces between them. We see incomplete osteons and we see completed round osteons up against other completed round osteons. As we get older, those little holes, all these little voids, fill in. And now we see incomplete osteons. It's hard to see. This is a little bit blurry, but you get the point. What's happening is the bone has rebuilt and rebuilt and rebuilt and rebuilt. So when the older individual, again around 70 years old, their bone looks older than the young bone. It also has a little bit less cartilage in it. These voids in death would have been in life filled with cartilage or other protein components. They're still there in some places, but you see there are a lot less of them in the older individual. Postcranial age estimation can also use that symphyseal face, the pubic symphysis. Remember, we met this earlier when we were talking about sex estimation. The pubic symphysis looked at and on has these very peculiar markings, and they go from phase 1 to phase 6. Here you see phase 1 is the younger side, phase 6 is the older side. If you look here, these have these ridges. They almost look like an elephant's tooth. That's just my own craziness. But all the way over here, they've lost those ridges. They've started to build up this ridge around the outside, starting to look more like a volcano, a caldera. This is extreme old age, so we're looking here at an old person like a man in his 70s, 80s, 90s. Over on this side, we're looking at a very young person, probably in their teens. We can do the same thing with sternal rib ends. You know where your sternum is, that's your breastbone, right in the middle. These are the rib ends that meet up to the cartilage that then meets up to the sternum, right? To complete the rib going across. So it starts in your spine, swings around, creates your rib cage, and then connects up to that cartilage. Well, over time, that cartilage will start to ossify. It will start to become bone. So what we will start to see is these nice clean rib ends start to build up these ridges around the outside, very similar to what we saw in the pubic symphysis. And these rib ends get longer and more jagged, and they get a little bit eroded, and in some cases very long. This all was cartilage when this person was young, and as they get older, this started to ossify, started to become bone. It's not going to suffocate them. Don't get confused. The body will do what it can get away with, but it won't do anything more. So what it actually does is stabilize the rib a little bit, but it also makes it a little bit more brittle. So it's a lot going on. Stature estimation is our last station here in this video. What we're talking about is understanding how large somebody was. Stature has, in part, has to do with height, but it also has to do with how big they were, how wide they were. And I'm not talking about fat, although we can determine if somebody was severely overweight in some cases, but we're not going to go into that much detail here. We're just going to stick with the basics. So how do we do it? Well, fundamentally, we take the long bones, the bones that are associated with height. So what are those? The long bones in the legs, not the arms so much, although we can do it if we need to with the arms. So what we look at is the maximum length of the long bones are then measured, compared to data of known individuals, in fact, known populations. We put it into a formula depending on what population this individual belongs to, meaning are they Asiatic, are they sub-Saharan African, are they a mixture of that? How do we do that? Then what formula we decide to put it into? This was invented by Mildred Trotter and Golding Glesser way back in the 50s to 70s. It has since gone through a lot of reiteration, and I will show you the formulae in a minute, but we're not going to be testing on it. We'll never have to look at it that much. First of all, which bones do we use? We use the long bones, usually in the legs, because those have to do with stature, with height, right? We do this in millimeters because we want this to be universal. We often use what we call osteometric boards. That is fundamentally two bookends with a ruler in the middle. Now, if you take Anthro 119, that is the forensics lab, we'll use some of these and do some of these osteometric estimations of how tall the individual who used to own that bone was. Now, you'll notice this here, this is not a femur in here, is it? That is a humerus. That's an upper arm bone. If we don't have a complete femur, or if we don't have a femur at all, or the tibia, then we'll go to the arm bones. There's other formulae for that. So we'll use whatever we have. We'll use the best we can get, okay? There are other ways of doing this, but we're sticking with it. We correlate this measurement to a stature data board. These tables and charts distinguished by sex and ancestry. Okay? The osteometric board here in the middle, like I said, it's literally just a pair of bookends with a ruler. So we'll stick that bone in there, measure its full length, farthest point to farthest point, take that measurement, throw it into this. This is a typical example using femur length. So we would take these things, you would put these things in, and then do these clarifications. You'll notice there is also a plus and minus. This is showing us the mean, and this is showing us the average mean. So we'll have to add that in depending on what population this person is taken from. So it'll be roughly this many centimeters, roughly this measurement in imperial, which is what we use, 5'8", okay? But we have to add a plus or minus in there. So that means this person could be as tall as maybe, I don't know, I'd go as far as saying from 5'10" to 5'6", somewhere in that range. But 5'8" is going to be the average there. Does that make sense to you guys? Now, presumptive versus positive ID. This is something new forensics students get hung up on all the time. Presumptive ID is what you presume this person is. That can go in with a lot of different things. Let me give you some examples. Driver's license, passport, boarding pass, jewelry or clothing, and the location. In other words, if they're on a specific airplane seat, like 29E. Is that presumptive ID or positive ID? It's presumptive because we don't know for sure if that's the individual. Let me tell you why. I bet you most people listening to my voice right now have had a fake ID to get into a bar or something like that. Am I right? That's a fake driver's license. It may not belong to you. The one this person was found with might not actually be theirs. That includes passports and boarding passes, of course. Recognizable clothing, come on. How many people here have lent a piece of clothing or jewelry to another human being? Right? Location of remains, airplane seat. Oh my goodness. I bet you everybody here who's been on an airplane has switched seats with someone else at some time or another. Because you ended up with an aisle seat and you prefer the window or vice versa, or you might switch throughout the flight. So all of these are presumptive. It gives us a start, but it does not give us a positive ID. However, presumptive ID is very valuable because you can get a positive ID from things like dental records. But there's not a single place to find all the dental records of everybody in the world. You have to know who you think this person is and then contact their dentist and say, hey, can I look at some of the x-rays you took? Positive ID is absolute proof of identity. Dental records, antemortem and postmortem x-rays that match. That is, if this person had a broken arm and they went in, they would have an x-ray of that broken arm when he broke his arm in 8th grade football, right? That's an antemortem x-ray, okay, or radiogram. Postmortem, we would look at that arm and say, hey, look, there's a break there. It's an old healed fracture. Boom, positive ID. Bony characteristics that are unique, that is, something interesting in the bone. For example, you can have frontal sinuses, which are kind of air spaces within the frontal bone, right behind the forehead, that will show up in certain x-rays, antemortem, and you can match those with what you're looking at post-mortem. And of course, our old friend DNA. Is any of this proof definitive? Is it fallible? You bet it is. DNA is fallible. So are all of these things. You can get it wrong, but it narrows down the chances significantly. Presumptive ID could be someone who is just missing in the area. You don't have to have a license. You can say, look, I'm looking for Hattie McCannelsburg, who was missing from this area from March last year. And if you find an older lady, you can start saying, okay, this skeleton is an older woman of European descent. That's what Hattie was, so it might be her. Then you can start saying, hey, Hattie's dentist, can I look at your dental records? Or Hattie's physician, can I look at the x-rays? Then you can figure that out. Or if you happen to have Hattie's children, that you can get a DNA match or something along those lines. So hopefully this all makes sense. This is all very important groundwork for what we're about to go into